If you've done months of physical therapy without any relief, it's not your fault. It's the fact that most physical therapists miss the frameworks that I'm about to teach you. And these are things that we teach every single patient that come through a moment, because we need to ensure that they understand the demands of their goals. They have to understand how to progress movements over time. And all of these things are absolutely crucial if you want to go from debilitating pain back to high performance. So let's get after it. First thing that you're going to get when you go to physical therapy is going to be the initial evaluation. So during the evaluation, we have to figure out what is somebody's goals, what's currently bothering them. And we have to figure out, like, what are we asking the body to do when a patient has pain? So there's a lot of patients that'll come in with chronic back pain and hip pain, and they'll get it after longer periods of sitting. Now, when we're looking at something like sitting, there's not a lot of muscle or force being produced here, right? There's not a lot of demands on a muscle. Sitting is mainly based off of mobility. So the main thing that we're focused on if someone talks to us about pain with sitting is we've got to assess some degree of mobility. Now, if that same person that's dealing with back and hip pain also says, I feel it when I squat and deadlift, well, now there's also a mobility demand, right? Because we have to be able to access the ranges where we're going to a squat and we're going into deadlift, but there's also going to be a force demand. So now I got to figure out how strong are they? So in the beginning stages, it might be focusing on the mobility aspect. So if I'm sitting in a chair, right, I'm going to be at about a 90-degree angle at my hip. So when you're at a 90-degree angle at your hip, the research shows us is it biases the hip towards more internal rotation. So I'm going to check your hip flexion and also your internal rotation to make sure that you have those adequate ranges in order to sit comfortably. Most people can sit comfortably or should be able to sit comfortably for a couple of hours. If you're sitting for like 20, 30 minutes, an hour, and your back and hips start to bother you, that's not normal. Those are things that should be addressed over time. Now, as we start to improve the mobility, if we want to get back to the higher level goals like squatting and deadlifting, we've got to actually focus on force, right? Because if we check off mobility here and we check off mobility here, let's use some different. Addressing the mobility might make your squat and deadlift feel better, but we still have to gradually expose you to the loads that were previously provocative. So with a squat and a deadlift, it might be that we do partial range of motion. So this can be squatting to a box or deadlifting off an elevated surface. And we want to make sure that it doesn't bother your hip or your back. You're able to train it with full confidence. From there, we're going to progress that to full range. And then when you're training full range, we're looking for a weight and a sets and reps that is totally fine, right? You shouldn't feel any discomfort. If it stays at baseline and it's tolerable, I'm okay with it. But for the most part, I'm not trying to push it anywhere. So whatever that weight is, you're just gradually going to increase that over time until you're back to your working sets. Now, with things like squatting and deadlifting, the speed of these movements are fairly slow. So I'm okay with this kind of progression. Partial range, getting to full range, working set. If you were to do things faster, let's say you were an Olympic lifter, not only would I need to get you back to your working sets, I would need to expose you to the same speed. And this is how we start to break down patients' goals. Most of the time you go through an evaluation and someone says something that doesn't even make any sense. If you have back pain and hip pain with sitting, I've had patients come into our clinic and they said their physical therapist was contributing their pain with sitting due to weakness of the hips. That makes absolutely no sense because when you're sitting, there's no force output. And then when you go do stuff like squatting and deadlifting, they don't even try to challenge the pattern, right? They go through something completely arbitrary. It's like, okay, instead of actually deadlifting whatever it is that you're capable of deadlifting, you end up doing like banded clamshells or like bird dogs, and you start underloading your body instead of doing what you're actually capable of. When people come in with pain, I'm trying to do the most challenging thing that they're still capable of doing that is tolerable, and then building from that. So if it's partial range, we start there. If they can handle partial range, then we'll go into full range. If they can do full range, I'm looking to see what their working sets are. And if they need speed, we'll work on speed. But during the evaluation, you have to understand how to reverse engineer somebody's goals, because if you don't know where you're building your rehab towards. If we understand where we're going, all we have to do is gradually expose you to those demands, and we call this graded exposure. So graded exposure, I kind of hinted at it already with the previous one, but the main thing that we're looking for is range of motion. So range of motion, load, and in the context that we're talking about, it's going to be weight. And then we're going to be talking about speed. And then we're going to be talking about complexity. So in a case of squatting and deadlifting, you're not doing things in a lot of different directions. So I'm going to use a different example. Let's say you're someone that's coming to us and you've been dealing with chronic ankle sprains. The first thing that I'm going to do is make sure that we restore ankle range of motion in dorsiflexion, dorsiflexion, plantar flexion, yes, inversion, and eversion. So depending on where you've had it sprained, the chances are this is the biggest one that most people are missing. They're missing dorsiflexion. So if this is our foot, if we're pointing it upwards, that's dorsiflexion. If we're pointing it down, that's plantar flexion. If we point it towards our pinky, that's eversion. If we point it towards our thumb, it's inversion. I need to make sure that we check all of these things off, right? Because if I'm not training to a full range of motion, there's a lot of things, compensations can occur. You're distributing the stress to a smaller range, so overuse injuries can be more common there. So the first thing we check off is always gonna be range of motion. From there, we start to load it. So let's say, to make this an easier example, we're focused on dorsiflexion and plantar flexion. I might be doing something as simple as a calf raise, just coming up and down. So from a load perspective, what are we looking for? Asymmetries. This could be left versus right. This could be towards norms. So if we were to do single leg calf raises, if you're from the age of 20 to 40, you should be able to do 30 single leg calf raises. So that's going to be a norm that we're looking for, 30 calf raises. As we start to build your calf raises and you get closer to 30 calf raises, I might be doing a ton of single leg calf raises with weights. And all that's going to do is now point out bigger deficiencies side to side. So if you were to do, let's say, hold a 60-pound kettlebell on your right leg and held the weight on your right arm, and you did 10 calf raises, but then on the left side, you can only do 5. That's an asymmetry left and right that we would want to address. So from a load perspective, the main things that we'll look at is what's different left versus right, and what are the normative values that we're trying to get to. Now, from a speed perspective, right, we don't always have that luxury of just slow contractions. When we're utilizing our calves, sometimes we're jumping, we're bouncing very quickly, and we need to express those force outputs in a shorter period of time. So we have to start to work on speed. And in that context, we might utilize something like plyometrics. So you might do something like a double leg into a staggered stance, into a single leg. And then now you're going from double leg, shifting the weight to one leg, and then bouncing completely on one leg itself. And this can be a progression that you utilize to improve your ability to produce force quicker and tolerate higher speeds of load. From there, it's complexity. We don't always get to move up and down naturally, right? So I might do something like forward and backward. And this is just doing, I'll go forward, I'll go back. I can do side to side. So it'll be just moving left and right. Other things that we can start to play with is a 2-to-1 pattern. So I can do 2 forward, 1 back, 2 forward, 1 back. I can do 2 to the side, 1 back, 2 to the side, 1 back. We can even start to do rotational. So as I'm moving, instead of coming forward, I might rotate my hip side to side. I can do slalom. So this is just more like a diagonal Z pattern, but there is so many different ways to increase the complexity. And if you're dealing with an injury like a chronic ankle sprain, we've got to check off the range of motion. We got to make sure the load is good. We got to make sure that you can handle speed, and we got to make sure that you can handle it in a lot of different directions. And ideally, everything is progressing towards the demands of your goals. Now, as you're reverse engineering and gradually progressing load to make yourself more resilient, one of the things that you might actually need in physical therapy is to take a look underneath the hood. And all that means is we're utilizing technology to figure out exactly how much force you're producing, exactly how much you're loading side to side. So a super simple example is maybe you've been in physical therapy and you've had a therapist say, hey, push into my hand as hard as you can. Like, oh, wow, that's pretty strong. But you can't objectively tell someone how much they're actually pushing against an arm, right? It might just be like, oh, this feels stronger than that side. But how do we know if things are symmetrical? So we utilize things like dynamometers, and it can be something as simple as anchoring something around your wrists. I'm gonna attach something to it fixed, and then I'm gonna pull as hard as I can in certain positions to measure exactly how much force you're producing in each of your joints and each of your muscles. And that's really, really important because you don't want to leave any stone left unturned. We've had patients that came in, right now I've had a patient came in after a shoulder injury, and we took this measurement, and there was a 38% asymmetry on the left compared to the right. So the left was 38% weaker compared to the right. And if I were to just do this, I wouldn't be able to know the exact number. So whenever we have the dynamo or the dynamometer set up, it's registering information onto the iPad, going to a cloud, and it's giving us the exact amount of force you produced, the asymmetry side to side, how long it took for you to get there, and all of these things play a bigger role. Now, another thing that we did was someone was cleared for ACL rehab, and we checked to see what their quad strength was. So we hooked the cuff around their ankle and they kicked out at a 90-degree angle. And there was a 20% deficit in quad strength, right versus left. So all of these things are really important because we have to keep making sure that we address these asymmetries, because if they keep persisting, we go to do faster things, you're gonna see those asymmetries manifest in a different way. So if this person has a 20% deficit in quad strength, and then you start to see them jump and then land, they might start to shift away from the side that they have that asymmetry. And we'll see this again. So it's not just utilizing dynamometers, but it's also utilizing force plates, which we have in clinic as well. So the force plate, I'm standing on two different plates, and I'm gonna keep my hand by my side, and I'm gonna go for a jump, and then I'm gonna stick it. And the force plate is gonna tell me exactly how much I'm decelerating my body, how much I'm concentrically pushing, and then how much I'm landing side to side. And we've had patients come in with the quad deficit, and they'll have asymmetries in eccentric force production, which is the lowering side. The asymmetries on the concentric, which is the lowering. This is the jumping. And then they have asymmetries in landing forces. So this is when they're coming down from the jump, going into the air, and then when they're actually landing. And these are things that are very, very hard. Sometimes you can see it with your eyes, but even when you see it with your eyes, it's hard to put actual numbers into it because you can't actually see force. If I am pushing into the wall, right? You'll see the result of something happening, like pushing away from the wall, but you won't know exactly the forces that are acting, the forces that are occurring as I'm doing that action, which is why we need to take a look under the hood sometimes. And this is very, very important if you've had surgery in the past or a significant injury where there's been an insult to the tissue, significant swelling, bruising, etc. All these things allow us to be a lot more precise with rehab. And there are so many people that come from other clinics where the physical therapist does something like this. Oh yeah, that shoulder's strong enough. And they come in here and then we see like a 38% asymmetry. You gotta clear that up before we do all the higher level things. Next thing that we're gonna talk about is stress. If we have too little stress, what typically is gonna occur is you're gonna have atrophy of muscles, you're gonna have decreased bone density. You're gonna have loss of aerobic fitness. And more. So why is this important? We gotta make sure that we don't lose muscle size, because muscle size is the foundation where we build everything else on, like muscle power. Same thing with bone density, right? The less we're training, your bones become weaker. And it's also tendons will get weaker as well. And other things that get neglected is aerobic fitness. Some people are just rehabbing and they're building strength and mobility, but they completely neglect aerobic fitness. And if your goals require you to be able to do things for 30 minutes, 45 minutes, for an hour, you have to have an aerobic fitness program in play to make sure that your cardio doesn't go down. Because you might be strong enough and you might have the mobility, but if you can only express those actions for 10 minutes, but your goals require you to be able to do that for hours on end, you're not going to be prepared from a rehab perspective. So you have to check off as many things as possible. And people will go from doing a lot of aerobic work, going into rehab and not doing any aerobic work at all. And they're just losing fitness constantly. So our goal is not to do too little stress, because nothing's going to happen. And then the flip side is true, where you have too much stress. And too much stress just leads to muscle pulls, achy joints. You get some swelling that can kind of occur, but in general, your risk of injury increases. Injury risk increases. So if too little stress is not good for you and too much stress can lead to increased injury risk, our goal is to find a sweet spot. And most of the time with the sweet spot, people have no idea where that is. So how do we know that it's just the right amount of stress? There's a couple of things that we look at. The first one is going to be your session RPE, and RPE is just going to mean rate of perceived exertion. We typically rate that from a 1 to a 10. 10 being the hardest session ever, 1 being a walk in the park. And for us in the beginning stages of rehab, we want a 6 out of 10, right? Because if we're just getting started, I need to find a baseline. And over time, I'm going to progress this to an 8 to 9 out of 10 session RPE. As we start to stack more sessions where you feel great, I'm more than happy to push the session RPE to a 7 and eventually to an 8 to 9 out of 10 RPE. But if it's your first session and I make that session an 8 or 9 out of 10 difficulty, it might be too much for you. Other things that I need to see is going to be technical failure. So technical failure is when form breaks or the lift slows down way too much. So it's going to be form break. We know that you're pushing it when the form starts to break a little bit. What I don't want to see is your form absolutely collapse. Other things that I want to see is that your lifts slow down. Now, if your lift never slows down, if you're just boom, banging out squats, it's probably not challenging enough for you. The research shows that the lift actually needs to slow down a bit in order for you to stimulate muscle strength and muscle growth. Same thing with form breaking, right? If your form never breaks, chances are you're not even training hard enough. So one of the things that we hedge ourselves to is technical failure. Do we train to the point where someone's form starts to break slightly? And do we train to the point where someone's lift starts to slow down a little bit? If we did, then we've trained to technical failure. Other times people will train to like complete muscle failure, and that's not what we're looking for. Once the technique starts to break down, or once the lift starts to slow down, that is good enough. And that's already the right amount of stress. So these are the two things that we typically hedge on. It's gonna be the session RPE and also technical failure. The last thing that you can also look at is just RPE for lifts. If let's say I'm doing a squat, right, and I keep rating it a 6 out of 10, well, eventually I can start to push it to a 7 to 8 to 9 out of 10, right? So it's not just a whole session, but it's for one specific lift. Other ways to look at it is also reps in reserve, RIR. So at the end of a lift, let's say I am doing deadlifts, and I'm doing deadlifts with 200 pounds. or my patient is doing deadlifts to 200 pounds, I might ask them, how many reps do you have left in the tank? And they might say something like, I feel like I've got 5 reps left. If they have 5 reps left, we're probably gonna increase the weight, right? Because 5 reps is like, there's still a lot left in the tank. I might work with someone until they increase the weights until they've got like 2 reps left in the tank, 2 reps in reserve. And then I might stay at that rep range until they've got about 3 to 4 reps in reserve, meaning they've gotten stronger. They can do more reps within that given set and rep scheme. But these are kind of different ways to measure, are you getting the right amount of stress? So to recap, the session itself is from a 1 to a 10, how difficult is it? In the beginning, we're starting a little bit lower, trying to build that confidence. When you're actually performing the lifts, are we getting to technical failure? Right? Do you get to the point where your form slightly breaks or the lift slows down? The lift itself, instead of rating the whole session, what's the difficulty of that lift? And then how many reps do you have left in the tank? If you have a lot of reps left in the tank, you're probably not stressing the system enough. But if you got like 1 to 2 reps left in the tank, that's probably an appropriate weight, and you can stay in that weight until you feel like you've got, anywhere from 3 to 5 reps left in the tank, and you can start to increase the resistance. So you drop down back to a lower rep in reserve, and you stay at that range until you have a high rep in reserve, and just keep rinsing and repeating this process. So we monitor stress in 2 different ways, and we're typically looking at within session and then after 48 to 72 hours. So what is the difference here? We have green, yellow, and red. If I'm doing an exercise and it feels completely fine or it's tolerable, right? There's no symptoms or it's tolerable, it's a green light. That means the exercise is okay to do. If I am doing an exercise within session, but then it's kind of getting a little bit worse, but it's not like unbearable, I might just wait. And then if it's like completely, you do an exercise and it just kind of takes your breath away, super sharp pain, or reproduces your symptoms at a very high level, we're gonna eliminate that for now. So that's letting us know what's happening within session. So if it's after 48 to 72 hours, if you feel baseline symptoms or it's completely tolerable, I'm perfectly fine. That means you can handle that volume. Within session, we're thinking about the exercise itself. After 48 to 72 hours, I'm thinking about the volume of the exercise that we're doing. Same thing with the yellow. If I am, let's say, doing my rehab session and then within 48 to 72 hours, I feel like a little bit of an increase in symptom, I'm gonna keep it there. Keep it there. And wait for my body to habituate to that response, or my patient's body to habituate to that response. So I would do that same exact session again, and hopefully within that next session, instead of an increase in symptoms, they actually feel no increase in symptoms, and it's a green light. So I'm gonna keep rinsing and repeating if it's a yellow light until it becomes a green. And if it's a red light, modify volume. Right? Like if you do a session and you finish that session and you're like, oof, my gait is a little bit off, I'm actually a little bit more achier than usual. If everything felt fine within session, it's probably more related to the volume. So we'll manipulate the volume instead of changing the exercise. Any exercise can be good or bad for you, right? It can be bad if you do too little, where it's below your level of function and you lose fitness. And it can be bad for you if you do too much and you're not capable of handling it. It's all about the dosage instead of the movement itself. So to kind of recap, within session, if it's baseline or no symptoms at all and it's tolerable, that exercise is good. If the symptoms kind of increase, but it's not like unbearable, I have weight here. And all that means is I don't want to do that initially, right? I want to poke the bear. So let's say I've been working with a patient now for 4 weeks. I know what they're capable of. I might poke the bear a little bit. I might go into the yellow. But if it's their first session, I don't want to step into the yellow because there's so many different ways to modify an exercise to make it green and completely tolerable. And the goal is, if it's red, completely avoid it. The goal is if we stay in the green, eventually yellow light exercises become green and red light exercises become yellow, and then we keep rinsing and repeating that process. The same thing with the volume. So when it's green light with volume, we're good to go. I'm not changing anything. I might even progress. If it's yellow light, I'm gonna repeat that same session until my response within the 48 to 72 hours is a green light. And then if it's a red light, you have a increase in symptoms, or you start to feel like you're walking funky, or day-to-day stuff becomes a little bit tougher. Let's say we had a heavy shoulder workout and we're rehabbing your shoulder, and like washing your hair becomes a little bit tougher. Those are times when we'll modify, right? Because it's a little bit too much load. And this is how we start to figure out how to figure out, with the stress perspective, is if it's something we need to change within session, or if it's something we need to change after 48 to 72 hours. Last thing to think about is the fact that rehab isn't always linear. You can do all the right things, but there's certain things that are just outside your control. So there can be things like sleep, stress, stress comes from work, social stress, and all of these things can pile up. So when we think of rehab, people are like, oh, I'm gonna see a physical therapist and boom, I'm gonna get better all the time, right? I'm gonna keep seeing progress, And that doesn't always happen. The more realistic thing that occurs is we have a good amount of progress, and this might be the first month, and then you have a day where things feel kind of off. And then, you build back up and things are going well, and then you might have a week where things are off and you're back on the wagon, and then things are off and you're going up. So I don't expect any of our patients to just constantly see progress without having any kind of minor setback. Because the goal of rehab is to always push a little bit, poke the bear a little bit, and do things that you maybe haven't done before or you haven't done in a while. And when those things happen, it's normal to have a little bit of swelling. It's normal to have a little bit of achingness, right? But those are things that we're doing to actually build our capacity. What you don't want to do is have flare-ups and these things occur because you're not doing enough, right? And this is kind of what this looks like. Most people that come in to see us with chronic issues, their capacity is here and their life demands are there. So what does this tell me? It just tells me that what they want to be able to get out of life is way higher than what they're currently capable of doing. And sometimes it can be something like running a marathon, or it could be running in general, right? So our goal with rehab in initial stages is to get rehab to meet the demands of life. And over time, actually, it's to make sure that we can actually rehab and build past it, right? Create a little bit of a buffer. So if we didn't have this, I would draw capacity a little bit higher, but since we're running out of room there, again, the visualization is like, you're gonna slowly increase your capacity so that everything outside of the gym, outside of the clinic is much easier, right? So your initial stages, your capacity is below your life demands. Short-term goal of rehab is to make sure your capacity meets your life demands. But I would never want to discharge a patient until their capacity significantly exceeds their life demands and there's a buffer. Because I always want to make sure that patients that come into our clinic are prepared for more, just in case those things do occur. Now, from a rehab perspective, when people come in, their pain is very high, and our goal is to decrease their pain. Well, one of the things that we need to take a focus on is function. We need to make sure that people improve their function over time. The biggest mistake that people make is they put such a huge emphasis on decreasing pain. And I think that's really, really important in the beginning stages of rehab, right? You got to calm things down. But not a lot of physical therapists actually know how to, excuse my French, build shit up, which is improving the function. So in the beginning stages of pain, your pain might be very high and your function's very low. Our goal is to help you calm the pain down while building your function. And this is what it usually looks like. As we see an increase in function, we will usually see a decrease in pain. But this isn't very prevalent in the beginning stages of, it's not very prevalent in the beginning stages of the rehab cycle. right? But as you start to see, as time starts to pass and our function starts to increase, the pain will start to decrease over time. And yes, that's probably an oversimplification, but it is something that I want to reassure our patients for, because the beginning goal is to make sure that you're not suffering needlessly, but the end goal is to make sure that you're actually prepared for the demands of life. So many physical therapists and so much of healthcare is understanding how to manage and reduce pain, but not a lot of people actually know how to improve function. So they reduce their pain and they start to feel better. They'll start to reintroduce their life tasks, whether that's running, playing a given sport, and they keep flaring up. Why do they keep flaring up? It's because they've managed pain, but they haven't actually managed their function. They haven't improved their function so that they can meet the demands of their goals. So when you're navigating this, remember that rehab is very nonlinear. You have ups and downs, and as you're navigating those ups and downs, hopefully you're building function and your current capacity will eventually exceed what life demands are. We're always trying to engage with our community, and I know this is a really, really in-depth video. So if you have any questions about the stuff that we talked about, any examples, if you want research papers, etc., whatever it is, drop it in a comment below. Our team is always on YouTube and making sure that we answer any comments that we get. And I hope this video gives you some insights as to what physical therapy can look like. I think oftentimes people just throw shit in a wall and see if it sticks, but you got to take an approach that's extremely calculated, especially if you have specific goals. So if you're looking for a rehab that is similar to kind of the points that I described, today, it's stuff that we can provide for you, not just in clinic here in New York City and Manhattan, and we have clinics in Queens, but we also do virtual rehab as well. And we've consulted with people in every single continent except Antarctica. So if you're interested in working with our team, check out the description and there's a contact us link. You just hit that link and you can schedule a call.